This is my management video of a case that was referred to me. The patient initially had cataract surgery by one of my colleagues a few weeks prior, and there was an anterior capsular extension in this region here that extended posteriorly to involve the posterior capsule, and you can actually see the edge of where the tear extended posteriorly. The primary surgeon left the patient aphakic, left a few sutures down here, and referred him on to me for further management. So how I approach this case is what I call a modified optic capture technique. And in these cases, I typically allow the eye to settle down for a few weeks and allow a bit of early fibrosis, which you can see over here. Next, for all these complicated cases, you always want to stain for vitreous. And I've injected triescence, and you can see there's quite a bit of vitreous. Afterwards, I've injected a 3-piece IOL, and I'm intending to place this in the sulcus. The area of extension is down in this region here. What I'm going to be doing is placing the haptics intentionally 90 degrees away. So area of extension here, the haptics will be 90 degrees away. You don't want to place the haptic in the area of extension because this will potentially cause the IOL to tilt. So I've placed the haptics here, and I like to place them above the iris initially because what I'm going to do now is something called a modified optic capture. And I call it modified because typically optic capture requires a 360 degree of anterior capsular rim. We don't have that here. But the benefit of allowing the eye to heal for a few weeks is that you'll get early fibrosis. And this will allow me to do a partial optic capture or modified optic capture. And you're going to see that here. So we're going to tuck the edge of the optic here. And there we go. And then we're going to do the same thing. Now I'm going to pause it here. You're going to see that once the optic is partially captured, that the shape of the anterior capsule is going to change. And so here, you have to be kind of a little bit gentle with this here. So we're tucking it in, and right there, you see the change now. So I call this a pseudo cat's eye appearance. Now we're going to put the haptic under the iris, and again, 90 degrees away. And then we're going to do the same thing on the other side here. And this basically completes the modified optic capture. And what I'm going to do next is and I do this for all of my dislocated IOLs or complex cases, is I'm going to ask the patient to move their eyes in different directions because it'll give me a sense of the stability of the complex. And so here the patient is moving their eyes, and you can see that there's zero movement. This patient ultimately ended up 20/20 at 1 week and has stayed quite stable at the 3-month mark as well. So to highlight, this is a unique case of a patient that has an anterior capsular tear that extended posteriorly to involve the posterior capsule. Placing a 3-piece IOL in the sulcus alone, I don't think is good long-term because in these compromised bags, the bag will eventually collapse, and this may affect the positioning of the 3-piece IOL. By optic capturing it or modified optic capture, you tent the the anterior capsule, and you prevent it from collapsing. So I really think this is the best method long term. Of course, other alternatives would be suture fixation, although there are some concerns with that down the road as well. And so basically this is how I approach this case. I hope you found this to be useful.